Royal Melbourne Hospital in here. Now we've loaded a 20-year-old male, 3 gunshot wounds to the lower back.
At the Royal Melbourne Hospital, an urgent call has come through from paramedics, rushing a critically injured gunshot victim to emergency.
3 individual bullet wounds to his back.
Royal Melbourne received. We'll see you in 15 over. Thank you.
In a gunshot victim, the injuries can be really unpredictable because some bullets are designed to actually explode inside the body cavity and do the maximum amount of damage. And what I'm thinking is there problems with bleeding that we need to stop that's going to cause this gentleman to bleed to death within a matter of seconds to minutes?
The gunshot victim arrives under heavy police guard.
So if the police are here, what are we doing about security?
The shooter is still on the loose, and there are fears he may try to get to the patient in hospital.
1, 2, 3.
That gunshot went off for a reason. What was that reason? Am I in a dangerous situation right now?
There are security concerns with that patient.
It's warm. It's such a very unknown, heightened experience to be in.
Paramedics who rushed the gunshot victim to emergency are giving Dr. Sarah and her team vital details about his injuries.
He's been shot with, we think, a small caliber gun. 3 gunshot wounds. He's pale, sweaty. He feels a little bit short of breath and has been grunting at times.
With a gunshot wound, that's high velocity, high force. It can cause almost any type of internal injury. It is a life-threatening situation.
We're just going to roll you and have a look at your back, okay?
The emergency team is searching the man's body for bullet entry and exit wounds.
So, got a entry wound right mid-thoracic, just off the right of the midline. Right loin, 2 on his left thigh, 1 on his left calf.
They identify 6 visible wounds. But worryingly, not all the bullets are accounted for.
X-ray there, guys.
An X-ray reveals a potentially fatal injury.
That's one of the bullets that's still left in this gentleman's chest. So this is his heart here, and it should be over in the middle of his chest, and it's not. It's squished over this side, so this lung has collapsed down quite significantly. And then the question is, has another of the bullets gone into the abdomen below the diaphragm, and is he bleeding from anywhere?
The bullet in this patient has actually punctured the lung, and the lung itself is deflated and it's leaking air into the chest cavity. It's really important that we go in and make a small hole through the chest wall and release that air and any blood that's in there so that it stops squashing the lung and the heart towards the other side of the chest. This is something that could definitely kill this patient if we don't release that pressure.
He's become tacky.
Yeah, very, very tachycardic.
We didn't know where the other bullets were, so if there was any injuries to his neck and to his spine, that's going to stop his breathing immediately.
As the doctors make an incision for the drain, the patient's heart is starting to beat very fast. His collapsed lung is losing air and pushing harder against his heart.
Just going to give you some more oxygen, okay?
Essentially, more and more air has come from the damaged part of his lung into the chest cavity, and that has pushed his heart over further, and eventually those blood vessels to and from the heart would have become so kinked that his heart would stop beating and he would die.
In Trauma Room 1, Dr. Sarah Whitelaw's team is carrying out a life-saving procedure on a gunshot victim whose lung has been pierced by a bullet. Police guarding the patient are on high alert, as the shooter is still at large.
What we need to do is actually make an incision to drain the blood and let that lung fully re-expand. And we need to do that pretty quickly.
He's sore, that's hurting him. We need more analgesia.
It's painful to have this done. This gentleman's probably got a lot of muscle, and that makes it quite difficult to actually get in through to the lungs. There's quite a lot of blood coming out of his drain in the chest.
With gunshot wounds, you always have to expect the worst case possible. You know, some will enter and they don't come out, or they'll enter and then shrapnel just gets spread in their body.
And I don't have any exit wounds. Is that right?
There's no exit wound.
It's very likely that there are still full bullets or fragments of bullets still left inside this patient.
Dr. Sarah's calling in a specialist surgeon to remove any remaining bullets in the operating theatre.
Sarah Whitelaw here, one of the ED consultants. We have a 20-year-old gentleman who, within the last hour, has had 6 gunshot wounds. He's having a chest tube put in on the right.
The gunshot victim needs a CT scan urgently to locate the bullets in his body.
You comfortable, Annalise, with that plan? If he stays as stable as he is, that we will go to scan?
I just want to know where, because if he's got the penetrating, he's got a gunshot to his abdomen, hasn't had a chance.
No, absolutely. It's just impossible to tell from the bullet hole itself whether that bullet's gone up that way or that way or that way or that way. So if it has gone into the abdomen, then there is a chance it could be causing bleeding. We need to keep the momentum going and get him to CT.
Moving the patient just a few metres from the trauma to the CT scanner is potentially deadly.
If that tube falls out or kinks, that lung could collapse again and that could cause the patient to become very unwell or even die.
Walked for 10 or 20 metres after being hit and then kind of collapsed down. So I don't think he's...
We're very used to dealing with patients that can't give us a lot of history. So it is useful to be able to get information about perhaps the type of bullet. It gives us information about the damage that bullet might do.
That confirms what we saw on ultrasound.
The CT scan reveals the dangerous extent of the damage the bullets inflicted on the victim.
The CT confirms that the chest drain is in the right place, that there is that ruptured lung and there's a bit of bleeding from the lung. There's also quite a few bullet fragments in the chest itself, along the surface of the ribs, and some bullet fragments around the liver as well. So it's hard to tell how many bullets are in the chest and the abdominal cavity because there's lots of fragments everywhere.
The police are obviously very keen to get the bullet.
There'll be a couple.
So
Dr. Sarah is handing over the patient to surgeons who will operate on him immediately.
So I think he's going to theatre for a laparotomy.
After a marathon shift, Sarah can finally head home.
That's one of the things that I love about emergency medicine. Most of the time we manage to make things a bit better. Sometimes we make it a lot better and sometimes we save lives.
That's hurting him. We need more analgesia.
Dr. Sarah's gunshot victim's life was saved after surgeons removed multiple pellets from his chest. They repaired his diaphragm, which had been ruptured by a bullet, a hernia, and part of his liver. All complications from the gunshot attack. He was discharged a week later.
Gunshot to neck, lots of bleeding, 15 minutes.
At the Royal Melbourne Hospital, a call has come through from paramedics rushing a critically injured man to emergency.
We got a gunshot wound coming in 15 minutes, shot to the neck, who's lost a fair amount of blood. Oxygen levels are low.
Emergency Dr. Michael Dunn moved from Ireland 18 months ago with the dream of finishing his medical training at a major trauma hospital like the Royal Melbourne.
I had no family connections or friends over here. It was certainly a big move and a scary move at the time, but I wanted to do emergency medicine. I only heard great things about the Australian healthcare system, so took the plunge.
Multiple holes in the neck, apparently. Sats 80, heart rate 120.
Director of Emergency Mark Putland has been a physician for 20 years. He's seen more gunshot injuries than most doctors in Australia, having spent time in the US hospital system.
I was in the States for 4 months. I was observing, looking at trauma systems and how they work. There, it's a daily thing. So we have to really work hard to bring the whole system together, make sure it works well for this.
What do you want me to do?
You want to do the right chest tube.
Yes.
They will be prepared for that and get trauma to the left.
Yeah.
Because we should assume that they're going to need one of these.
Gunshot wound to the neck is a very high-risk injury. There's a lot of important structures very close together in the neck. Potentially major vascular injury, so the big arteries, veins running up and down to the brain, which has pretty dire consequences, both in terms of supply to the brain and just loss of blood.
Dr. Mark is gathering a crack team of specialists to treat the gunshot victim.
G'day, how are you? Paul, ED Director, hey. So I'm going to team lead. Rose is going to provide surgical expertise to the procedural people because there's potential for a bit of procedural. You're what? ENT, did you say?
Yeah.
Hence the glasses, great. We also had the head of anaesthetics down, which is fantastic. Probably one of the best people to be managing that upper airway they've got in the whole place. Has everyone got face masks on? There's a lot of external bleeding from this neck, according to the radio. That could be spurty. Everyone's elevated, everyone's a bit nervous. And I mean, it's important that people take that nervousness and turn it into a positive feeling for themselves, because that same adrenaline, that can be terror or it can be excitement.
You train for this, you train for dealing with the unexpected. You do see things for the first time. So you have to be prepared and dynamic and adapt.
Sats are 80%, heart rate 120, blood pressure 100 on 40, GCS 15. That was about 10 minutes ago. A lot could have changed since then. Lisa, you're in charge of the airway for the time being. When anaesthetics arrive and take the top end, if you move to a potential surgical airway, that'd be great. And Rose will be there to support you with surgical assistance with that. Michael, if you take care of the right finger thoracostomy, David, you're taking care of the left finger thoracostomy. And Thomas, you're going to have a look at the heart and then the rest of the abdomen on the FAST scan for us. Thank you. Bullets do a hell of a lot of damage. So anything's possible, but we're prepared for big airway injuries. There's a lot of things that keep a person alive packed into the neck, so it's critical. Just arrived and looking pretty crap.
This is a male in his 50s, no previous medical history, meds or allergies. He has received a single gunshot wound to the left side of the neck, just under the angle of the jaw, with apparent track through to the contralateral side with increasing swelling on the right-hand side. So, airway is my primary concern, although it is intact at the moment. He has increasing dysphagia, presumably to the swelling. There is no external hemorrhage.
So, single entry wound, is it?
There's one hole in his left neck and there's a big swelling on the right neck.
Okay, his trachea is midline, chest is good air movement blurry. Let's get fast on.
Good.
There's a wound to the left side of the patient's neck with no exit wound that I can find. So I suspect the bullet's still within the patient's neck and he could die from that injury.
Let's assess his chest and abdomen in the normal way. Minimal handling around his neck, and we'll let anaesthetics have a look and we'll make a controlled plan at whether or not we secure the airway now. His main issue initially was his airway was a bit threatened. You get a big swelling developing from that pushes your windpipe across to one side. The risk with this sort of injury is that the only thing keeping the man's airway open is his own muscle tone and his own, basically, he's sort of clinging on to life. What's the front of the neck look like if it comes to it, Michael?
The front neck looks okay, actually. It's all predominantly the side of the neck, yeah. Shouldn't be any issue. I think we need to go surgical airway.
A surgical airway involves making a cut into the throat so the man can breathe through a tube. But it's a very risky procedure, as the doctors haven't found the bullet. Dislodging it could be catastrophic for the patient.
Point here and no exit with swelling on the other side, so it's obviously trapped.
You've got a lot of experts in a room, and we've got to make sure this is an orchestra, not a jazz band. Now, Anita's had a good look with the little video, and we decided to get the surgeons to make a cut to the front of the neck and put a tube in that way. All right, some local anaesthetic with adrenaline. Okay, so team, the plan at the moment is the ENT surgeon's going to do an awake local anaesthetic front of neck access.
An awake is where the surgeon cuts open the windpipe and inserts a tube while the patient is conscious.
Okay, scalpel, please. Yeah, scalpel.
It's an extremely rare procedure, but the swelling of the man's tongue and build-up of blood is suffocating him.
I personally have never been involved in the awake surgical airway before. Typically, it's something that we wouldn't do in the emergency department. It's sometimes done in the intensive care unit when the patient's sedated.
A little bit of pushing on the front of your neck there.
We initially enter under the Adam's apple, and the tube would probably go in about that far. It's extremely distressing and uncomfortable for the patient. It does temporarily give the feeling like they're choking, but it's life-threatening and a life-saving procedure.
He is getting agitated. That I feel uncomfortable about, I must say.
Bit of pushing it, you're doing very well.
Is the tube in?
Yeah, tube's in.
Tube's in. Get him off to sleep, Michael. Get him up to sleep.
How much longer?
Give him 100.
The airway is secured, but the trauma team now has another crisis on its hands.
Arterial bleed? Yeah, arterial bleed at the base of the neck.
After securing the airway, we realised that the patient has some arterial bleeding from a small artery higher up. This is certainly an extremely dangerous situation for the patient. He is essentially fighting for his life, and the interventions that we do have to be done quickly and have to be done correctly.
I'm going to start the O-neg now that we've got external bleeding in significant volumes before he gets into more trouble.
We're just going to pack it now.
Just going to pack him in theatre.
The bleeding means it's too dangerous to do a CT scan to find the bullet.
Just hook it up and ready to go. He's got significant external blood loss now.
Time's running out for the patient, and he must be rushed straight to emergency surgery.
All the activity dislodged a bit of blood clot. Plus his blood pressure went up in response to what we were doing. It was a bit stressful for him, so that may have stimulated a bit of bleeding. So then they precipitated a change of plans. Rather than secure the airway and go to CT and see what damage is done, it was secure the airway, go to theatre. Let's go. And I might just come up just to see that everything's good.
Oh, it was pretty intense there. Thankfully, the airway is protected now, so he's going up to theatre to have some bleeding addressed.
The emergency team has stabilised the man, but he remains dangerously ill.
This is one step in the process of actually treating the patient. So his life is still very much on the line.
50-year-old male, gunshot wound in the neck, multiple holes in the neck, a lot of external bleeding.
Dr. Mark's gunshot victim was clinging to life when emergency doctors performed a rare procedure to let him breathe.
Tubes in, get him off to sleep, Michael.
Following 6 hours of surgery, the man went to intensive care. Thanks to the surgeons, he survived and was discharged from hospital a week later.
We might get some fluids, that's all right.
Over in Trauma 1, Dr. Michael Dunn is preparing for the arrival of a man being rushed in under a heavy police escort after he was sprayed with bullets.
So we have a patient coming in who apparently has multiple wounds to the face and upper chest. So the concern is that there's all fragments into multiple places and cause damage.
With the extent of the man's injuries unknown, Dr. Michael prepares for every possibility.
With gunshot victims, they can deteriorate in an instant, so where they've been shot, how many times they've been shot are all critically important. Different guns will also have different risks. So a handgun will leave a single tract most likely and oftentimes don't have exit wounds. A rifle would more likely create an exit wound, where shotgun pellets tend to disperse in multiple places. We have to be on high alert and ready for the worst case scenario when they arrive.
Next one. Keep going, keep going. Yes.
But looking at him, it's a little bit hard to find all the wound.
Is there a reason we're lying face down?
He's not.
Sure.
Okay, so we can transfer across the bed and then we'll listen for handover, please.
That's it. Well done. He's been in his car. Obviously, he's been shot at. Multiple bullet holes to the car. The car's then sort of rolled to a stop. He's self-extricated, walked into a nearby house, called 000. First crew found him on the couch with obviously multiple bullet holes. He's had 50 miles of IV fentanyl, which actually calmed him down quite well.
Thank you very much.
Although the man's been shot multiple times, he is conscious and Dr. Michael can speak to him.
Open your eyes for me. Can you see me okay, yeah? I think it is important that the patient realises that we're not there to judge them, we're only there to treat them. Pupils are equal to 3. It can be quite scary and quite nerve-wracking, but we have to try and control the adrenaline, control the nerves, and just focus on the patient. So while some people may appear calm in a situation, every single person's heart is going extremely fast in that room.
No obvious long bone injuries.
The priority is for us to have a look at the back just so we can clarify exactly what was there.
Okay.
1, 2, 3. Let us do all the moving, mate.
The emergency team needs to quickly find the bullet entry holes and see if any bullets have exited the man's body or if they're still lodged inside.
Oh, there's one in sort of the middle, the one from
and the left upper shoulder.
Left upper shoulder.
On examination, we find that there are 3 significant wounds, one to his left shoulder, one to his upper back in the midline, and also one to the right side of his head.
He's got a gunshot wound to his right temple with a large hematoma over the right temple.
The hematoma means the man is bleeding around his brain, and there are no exit wounds, so the bullets are still in his body.
At this point, we're quite concerned that he has possibly some brain injury, possibly some damage to his spine, heart, and lungs.
Squeeze. Squeeze.
Yeah.
Squeeze on this side.
Yeah.
Right, not
There's nothing.
on the left.
Push me with your foot. Push, push, push.
Dr. Michael asks the man to push with his feet so he can check if his spinal cord is working normally. The man isn't responding. It's now vital to find out exactly where the bullets have gone.
I would at this point describe the patient's condition as critical. The bullet wounds are certainly surrounding some significant organs that can cause life-threatening injuries and potentially could lead to this patient's death.
That's not good.
Okay, so let's just assess some parts of chain.
Back in Trauma 1, Dr. Michael Dunn's team is fighting to save the life of a man who was gunned down in a hail of bullets.
Yeah, you're ready,
Can we just get that blood pressure cycling at least every 5 minutes, please?
There are 3 significant wounds in this patient, one to his left shoulder, one to his upper back in the midline, and also one to the right side of his head.
With one bullet suspected to be lodged in the gunshot victim's brain, Dr. Michael now needs to find the other 2 bullets with an X-ray and ultrasound.
Just checking for pneumothorax here.
With the bullets still lodged inside, we just have no clear idea on what direction the bullets were going. He was shot once to the shoulder, so we don't know if that's traveled through the chest and into the abdomen.
We got pneumothorax on the left-hand side.
But the bullet isn't in the abdomen. Instead, the patient has a hemothorax, where blood is dangerously pooling outside his lung.
This would indicate that one of the bullets has actually penetrated the lung itself.
And we've got small pneumothorax on the left.
If the bullet has penetrated the lung, it could collapse. But that's not Dr. Michael's only concern.
Stats are 90%, 89-90%. Can we get a temperature as well?
His hands are frozen.
He's cool peripherally, but we've got high flow oxygen on. Heart rate of 40.
The man's vital signs are plummeting. He's becoming increasingly distressed and could go into cardiac arrest any minute.
Can we get a salt collar?
You've been shot in the shoulder and it's on through your neck. We want to try and keep you still.
The patient is fighting for his life, and the emergency team needs to stabilise him so they can get a body scan.
We have to figure out where those bullets have gone and the track they've taken and what organs or structures they've injured along their path.
All right, let's get in the pain relief and then let's get around to CT.
On go, ready, steady, go.
Dr. Michael Dunn's gunshot victim has a suspected brain injury and multiple bullets lodged inside his body. An urgent 3D scan should show exactly where they are.
We know where the bullet wound entrances were. We're just trying to see where they ended up. We're doing a contrast scan of the head, neck and chest to have a look to see if there's any injuries to the major structures there.
The concern is that the man may have serious brain damage, as well as injuries to the spine, heart and lung.
Yeah, he does have a lot of contusions there. And that's gone through the lung and out the back, isn't it?
The bullets have travelled at unexpected angles through the body.
That's the skull one, temple, come down. That's the shoulder one come down, and that's the back one come down. So he must have been forward when he was shot.
The bullet that entered his right temple has ended up in the front of his neck, and that's led to some skull fractures, some bleeding, and also some swelling to the brain itself. The bullet that entered the midline of her back has actually travelled through the left lung itself, and that's led to some bleeding in the lung. The third bullet has gone in and hit his shoulder blade and seems to have stopped there.
Still under police guard, the man is now being taken back to trauma so he can be prepared for life-saving surgery.
So the next step is putting a tube into the chest so that we can remove any air or blood that's actually pressing on the lung.
Your lung's bleeding. Right, so I think we just need to drain into the blood. Okay, stand it back.
Probably the most important tract we have to focus on is the head wound, because we know that there has been a skull fracture, there's been some brain damage, and likely there will be increasing brain swelling.
While the medical team continue to work to stabilise the man, neurosurgeons are analysing his brain scans.
Once we open that cavity up, it's going to be really hard to fix.
They are certainly life-threatening injuries. There's a chance that this actually might deteriorate and it may get worse. The next 24 hours are hugely important. Open your eyes for me. Can you see me okay, yeah?
As for Dr. Michael's critically ill gunshot victim, who was rushed to hospital after being sprayed with bullets,
One sort of in the midline.
Midline, and then sorry, the left shoulder, upper left shoulder.
he had the blood drained round his lung and underwent immediate neurosurgery. Surgeons cut out a section of his skull to relieve the pressure and remove bullet fragments from his brain. The man spent 2 weeks in intensive care, but incredibly survived. He's now undergoing rehabilitation for a brain injury, but doctors are hopeful of a good recovery.
Certainly a lot of patients who've been shot 3 times to the chest, to the back where the spine is, and also to the head, most of them won't make it to hospital, so he's been extremely lucky given the injury he's had.
Paramedics are bringing in a teenager who's been attacked.
We've just had a call come through about a young man who's been hit with a machete to his forearm.
Hearing of a machete attack with potentially gruesome injuries, Dr. Jason calls on emergency Dr. Michael Dunn to lead the case.
There's a trauma call. Sounds like isolated machete to forearm, but tachycardic.
Tachycardia is a bit of a worrying sign for us. It basically means the patient's heart rate's fast. Now that can be caused by blood loss, which is our biggest concern a lot of the time in trauma, which we have to address very quickly.
Heart rate's 130, which could be the fact that he's panicking in pain or he's lost a lot of blood. So we're going to get some blood down and get some IV access in case we need to give him some blood that he's lost. Blood. Depends how bad this guy is.
Each injury is different. I mean, it's so difficult to know over the phone how bad each injury is, and you have to wait till the person arrives. So you really have to be prepared for anything as small as a simple cut to the arm to potentially an arm being nearly amputated.
The young man who was attacked with a machete is just 19, his right arm bleeding badly.
The paramedics in the field have put a compression bandage on to control the bleeding.
Okay. Do you want to hop across there, you think? You be all right? Good man. Cool.
Dale's had gotten into a bit of an altercation with some people as he was going round to a car. Has allegedly been struck with a machete. He has sustained probably a good 10 centimetre lack. Looks like there's bone on view. I've taken a photo to show you.
We're just going to have to take the T-shirt off.
How much blood on scene?
I don't really know because he's walked up and down the street. It's a big trail for like a good 20, 30 metres.
It's difficult to say how trauma affects people. I mean, Dale in particular seems extremely calm for someone at his age who was struck with a machete.
Dale was helping out at his dad's place when a car drove up.
It's 4 guys against me, and yeah, all of them had weapons. It's just gross. It's like I looked down and then all I could see was like my literal wrist. So it was like...
The worry with these ones is they have an injury to the arm and everyone focuses on that and they have some sort of stabbing to the back but no one's checked and they're actually bleeding somewhere else. So you have to give a full head-to-toe check and make sure you're not missing anything.
With the knife, did they hit you anywhere else?
No, it's just
Now we're ready to take the bandage off. And the real question probably in everyone's mind is what's going to happen when we take that bandage off? Is there going to be a significant amount of bleeding? What exactly we're going to uncover and how severe the injury is going to be.
Chest is clear. All his other numbers are fine.
With the tourniquet in place, Dr. Michael and the team start to remove the bandages.
What do you think?
When we take the bandage off, we see there's exposed muscle, exposed tendons, potentially tendon injury. Thankfully, we're not seeing any bleeding arteries.
Dale, taking a photograph for your file, okay?
Yeah. So, obviously, a little cut here. There's a little bit of a blood vessel bleeding here.
Trauma surgeon Dr. Dan Marasia is checking to see if Dale will have any permanent damage.
Just need to check to see if the tendons that are running along here are affected as well. So can you straighten your hand out like that? Good. Lift your wrist back, perfect, and relax. And then push up against my fingers, good. And you can feel that through there? Yep. And same as that side.
He's obviously cut through some muscle, but he doesn't damage any major tendons, blood vessels, nerves, so.
With a wound like this, the risk of infection could be very serious. So we need to take extra precautions in the next 24 hours to make sure that that wound is going to be cleaned thoroughly and the risk of infection is minimized as much as possible.
Give me some antibiotics and top wear plastic surgeons. Okay.
Dr. Michael applies a plaster cast to protect Dale's arm until he gets to theatre.
I mean, I think you actually got struck at a pretty lucky spot. And I'll have to give it a good wash out in theatre and close it up.
Yeah.
But the fact that your nerves and tendons are fine now means we'll be fine going forward, okay? All right. Do the plastic surgeons say when they're going to operate, or do they?
No, they said they're going to.
Don't know yet. Okay. We'll get you up to the ward, and that's it. Best of luck with everything, all right?
Dale is keen to put the horrifying ordeal behind him.
Just trying to get through it. Just want to go home, man. Go speak to my dad and crack open a beer. That's about it.
19-year-old Dale was attacked with a machete.
Heart rate's 130, which could be the fact that he's panicking, in pain, or he's lost a lot of blood.
The machete left a deep gash in Dale's right arm.
It's like I looked down and then all I could see was like my literal wrist.
Just need to check to see if the tendons that are running along here are affected as well. So can you straighten your hand out like that? Good.
Fortunately for Dale, the machete missed major tendons, blood vessels and nerves.
I want to get out of here as quick as I can. Go speak to my dad and crack open a beer.
Dale had surgery to close the wound and he was discharged 2 days later. A call has just come through from paramedics, rushing in a man who's been stabbed in a violent attack and could be bleeding to death.
So let's get the room ready. We're going to go into trauma 1 or 2? Trauma 1. So we know that there's a man coming who's coming in police custody, who's been stabbed on the left-hand side of his body. And we anticipate that things might kick off in terms of not wanting treatment, not wanting to be there, being scared, having pain.
The man is under the influence of alcohol. He's extremely agitated and police are standing by.
Back out. Ready, set, go. Okay. He says he was stabbed twice. Not sure where it happened. Went home. Difficult to assess the depth of his wounds. He's reluctant to take close with. He's got significant thoracic pain. Says it's sharp. Says it stops him taking a deep breath.
The man waited 2 hours after the attack before finally contacting a family member who convinced him to go to hospital.
I'm going to lay him flat. Let me have a look at his heart. I don't know if the stab wound's gone into his chest or his tummy. And so that's why we're trying to get the ultrasound and figure out if he's bleeding internally. Once I've done the ultrasound, I'll sit you up, matey, okay? I just want to get an ultrasound of you, and I won't do that for long. Now let me... To be able to figure out if he's got bleeding within his abdomen, we need to lie him flat. I'm really trying hard to get him to trust me, but this patient's really agitated, and so that is proving really difficult.
Just move the chair up, please.
You want to go up a bit? All right, no problem. How about that?
Maddie, I want to let you know why I want to lay you down. Because the ultrasound only works if you're laying flat.
Give me the morphine.
I'll give you the morphine, and then what I'm going to promise you...
water, please, mate.
I'm going to get you something to suck on in your mouth.
Drink, please.
This man has a lot of pain with breathing, and so I know that things have gone deeply into his body. I just can't figure out if it's into his chest or his belly. He is really scared, but I'm realising that he doesn't understand the severity and the life-threatening nature of the stab wound.
I can't lay down, I'm telling you, it hurts.
We'll give you some medications.
There's much pain there when I go down. Please take this off.
And I don't know who stabbed him, but they'd stabbed him such that he could bleed to death.
Surgeons are standing by, but they need conclusive ultrasound results before operating.
My hand, you can squeeze if you like.
Go back up.
We will in just a second, okay? Just
hold
get
on.
some pictures, yeah.
There's a little bit of free fluid there.
Oh, mate, please.
So there is a little bit of free fluid. All right, matey?
Yeah. It's a chip.
Hey, mate, I reckon you've been stabbed in the belly, and I reckon it's popped into your tummy, and I reckon it's bleeding. You'll get sick and die if you don't have an operation. We're going to knock you out for an operation.
Give me a drink first.
No, not at the moment. We can't do the operation if you have water in your stomach.
I'll give you some rice. Here you go. All yours.
The team deny the man a drink, as the fluid could end up in his lungs and he could choke to death.
I just need a drink and I'll wait. I'll help me out.
I'm happy to give you ice. There isn't anything else we can do.
Just give me a drink.
The patient is becoming increasingly aggravated.
If things get out of control, we have to be careful for our staff's safety to make sure that everyone's safe and the patient's safe. I know he's been stabbed and I know he's bleeding internally and I know that he's not able to make the right decisions for himself, and so my job is to take control of the situation, so take the choice out of it for him.
Dr. Emma makes the decision to sedate him.
I'm giving you some medication through the drip, okay? It's called ketamine. Have you heard of that before?
No.
It makes you feel a bit weird, but we're here to look after you, all right?
I'll be gone in a minute.
Hope not. We're here to look after you, mate.
This man needs sedation and he needs a drug that won't affect his blood pressure and heart rate. So I've given ketamine.
You just relax. I'm just going to lean you back a little bit. Not too far.
Good.
I've gained control of the situation now, but I get the feeling that I can't just relax.
All right, yeah. All right, code break, please.
In Trauma 1, Dr. Emma West has called for urgent help with her out-of-control stabbing victim.
So I need you to hold him down. So I'm going to give him a couple of milligrams of Medaz. I think he's having emergence reaction from the ketamine. Now, you hold his arm down. Where's that Medaz? Good.
It's taken 6 security staff and police to restrain the aggressive man.
When he jumped off the bed, I screamed out for some help, called a code grey, and I knew that would result in security staff who are expert trained at helping me hold down a patient like this so that I can give him sedation so that he can get urgent care that he needs.
You've got 10 and 10 there. Thank you. It's all right, it's okay. He's an injured man. We just need to be really safe with him. And he's had some medications that have... Excuse me? He won't listen to you. Because he's really sick. So I need to put a drip in there. So hold him there and hold that arm out. Good, thank you.
The sedation is beginning to kick in, but its effects will only be temporary.
So, I think if we wait for his sedation to wear off, he's going to wake up and just be really, really difficult. So I think we need to get control of the situation. We can't reason with him. We can't get him to lay flat. We can't get him to do what we need. So I think we're going to have to intubate him now. You've got theatre ready?
They are aware.
OK.
In order to keep the man unconscious, Dr. Emma decides to take over his breathing and put him into an induced coma.
I was trying to meet him and talk to him so that maybe he felt that he had an ally, but his brain wasn't working that way because drugs, alcohol.
I can see untitled trace. Yeah, there is. I see no.
Yeah.
With the patient now under control, Emma's job is done. Whether he lives or dies is now in the hands of the surgical team.
I think you should start rolling. And there's lots of blood in his belly.
As he leaves the emergency department and heads upstairs to theatre, Emma's intense shift ends with paperwork before she can clock off.
My drive home is a little bit of wind-down time. Things percolate through your mind. You think about the case for a bit and you think, could I have done that differently, or did they get enough pain relief? So it's just that 45 minutes I find so important, because then I walk into the whirlwind of 4 kids all wanting my attention as soon as I walk in the door. And, you know, I'm their mum, so I have to be 100% ready for them too.
All right, code grey, please.
Dr. Emma's aggressive stabbing victim survived the violent attack. Thanks to her team in emergency, he was rushed to surgery where the internal bleeding was stopped and his stomach repaired. He spent a few days in hospital before checking himself out. He didn't return for any of his follow-up appointments.